Thanks, Bangladesh Society of Cardiovascular Intervention, for inviting me as a speaker here. At the same time, I am feeling very much delighted and proud because of presence of my two directors, Professor Abu Azam sir and Professor Abdullah Al Shafi Majumder sir, and my teacher from the beginning of my teaching institute, NICVD, Professor Dr. Khalid Mohsin sir. So I am Professor Dr. Khalequzzaman. I will be presenting on antiplatelet therapy before, during, and after percutaneous coronary intervention. Good evening to all, and assalamu alaikum. Okay. I will be speaking on these contents. The coronary intervention initiates the thrombin generation through endothelial damage and the plaque disruption, which creates a thrombotic milieu inside the blood vessel, ultimately leading to thrombus formation, which the thrombotic tendency may persist for weeks, months, or even years together, or even after stent endothelialization even. So the antithrombotic therapy, particularly antiplatelet therapy, will play a determinant role to produce acute and long-term good outcome. So in this picture, you can very much appreciate that the interplay between the platelets, coagulation, and the inflammatory mediators and modulators plays a key role in the thrombotic complication following endothelial damage, following ulceration, following fissuring, following rupture of the plaque. So here, the crosstalk or interplay between the platelets and the other factors play the determinant role in the production of the thrombus that may lead to subacute, acute, near-occlusive thrombus or totally occlusive thrombus inside the blood vessel. On the other hand, it may lead to also development of plaque healing and progression of the atherosclerosis. So what the antiplatelet agents can do? Antiplatelet agents can reduce this periprocedural damage, at the same time reduction in the acute and subacute stent thrombosis. Apart from this, in the setting of the acute coronary syndrome, it reduces the thrombus burden as well as flow obstruction in the coronary arteries. So let us have a recapitulation about the name of the antiplatelet agents. I will not go in details of that. You see the COX inhibitor, P2Y12 receptor blockers, GP2B2A inhibitors, and phosphodiesterase inhibitors. Apart from the COX inhibitors and the P2Y12 receptor blockers, other antiplatelet agents are very selectively used, and majority of the drugs are in the list of 2A, 2B, or even 3 indications in ESC or ACC guidelines. So we will be very much limited to our discussion on COX inhibitor and P2Y12 receptor blockers. So although over the last 4 decades there has been substantial evolution of the antiplatelet treatment, yet then still now it is the aspirin who is forming the backbone of the treatment of the antiplatelet regimen in the PCI. Apart from aspirin, addition of one of the 3 antiplatelet P2Y12 receptor antagonists will form the dual antiplatelet therapy, which is still now considered as the cornerstone of treatment for patient undergoing percutaneous coronary intervention. So who is PCI we should add, in which situation we have to add, and how much we have to continue this P2Y12 inhibitors. It depends on the potency, definitely, on the efficacy, definitely, safety, clinical scenario, and evidences. But one thing is important to know, that which P2Y12 inhibitor is superior to one or others has been a topic of debate for several years. Now let us see the evidences. In the Plateau trial, it has been shown, the study has been done over 18,000 patients, and it has been shown this ticagrelor-based regimen produces substantial reduction of the death from vascular causes, myocardial infarction, and stroke. But on the other hand, a Pijous trial showed, and this trial has been done on the patient with elective PCI, this trial failed to show any superiority of the ticagrelor over the clopidogrel in terms of prevention of the periprocedural myocardial necrosis. The Triton-TIMI-38 trial that has been conducted over 13,000 patients, and all the patients are suffering from acute coronary syndrome. They showed that, or they found that the prasugrel therapy significantly reduces the rate of ischemic events, cardiovascular death, myocardial infarction from stent thrombosis, or stroke at a median follow-up of 14.5 months. But there is a bit increased risk of major bleeding. So what is about the ticagrelor versus prasugrel? The Prague 18 study, they fails to demonstrate superiority of one over other in head-to-head study, but in EASER REACT 5 trial, which has been published in 2019, shows that the prasugrel-based therapy significantly reduced the death, myocardial infarction, or stroke. So what it appears is that according to potency, it is the prasugrel which is most potent, and in the acute coronary syndrome with PCI, it is the prasugrel which is the preferred agent, and in chronic coronary syndrome, patient undergoing PCI, it is the clopidogrel which is the first choice. If the patient has got thrombotic risk high, so prasugrel should be the preferred agent. If the patient has got high bleeding tendency, the clopidogrel should be the preferred agent in compared to other P2Y12 inhibitors. So let us see the guideline. The 2017 published guidelines by ESC, the latest one and the current one. Before PCI, during PCI, and after PCI. What is before PCI? Before PCI means so long the patient angiogram is not done and the coronary anatomy, you don't know the coronary anatomy. That is the before PCI. And during PCI means at the time after the coronary angiogram is done and we know the coronary anatomy, we know the coronary lesion, at that time in-lab administration of the antiplatelet agents is known as the administration of the antiplatelets during PCI, and after PCI that is the maintenance therapy. So if we consider the chronic coronary syndrome, the aspirin should be always there. We should have loading dose of the aspirin before going into the cath lab. Number two, the pre-procedural administration, or so long we don't know the coronary anatomy, so long coronary angiogram is not done, the routine administration of P2Y12 administration has no benefit. So there is no recommendation for giving the P2Y12 receptor blockers before going into the coronary angiogram. During PCI, after the coronary anatomy is known, or there is high probability of the PCI, there is 2B indication to give the P2Y12 receptor blockers. In these cases, it is the clopidogrel which is more preferred here in compared to prasugrel or ticagrelor. And following PCI, it is the default recommendation that patients should have aspirin and the clopidogrel for 6 months, followed by aspirin monotherapy lifelong. And this is the default strategy. But in selected situation, the duration of the DAPT may be shortened even up to 1 month, or maybe lengthened even up to 30 or 36 months. If we see the non-ST elevated acute coronary syndrome, again aspirin is a strong recommended drug which should be given in a loading dose before going into the cath lab. Here, the administration of the P2Y12 receptor blockers is strongly contraindicated, particularly the aspirin. Before you know the coronary anatomy, don't give the P2Y12 receptor to this patient. So when you know the coronary anatomy, you have to give the loading dose of the P212 inhibitors, and here it is the prasugrel, which is the drug of the choice, or ticagrelor, that is also a good choice. If both are not available, clopidogrel is again a preferred agent to give it after the coronary anatomy is known. And following PCI, DAPT for 12 months, again it can be shortened or it can be lengthened. What is an acute coronary syndrome? When there is acute ST elevated myocardial infarction. Here, as the primary PCI is the default strategy to a good outcome. So here, P2Y12 inhibitor can be given. Rather, it is encouraged to give a loading dose of P2Y12 inhibitors just before going into the coronary angiogram, and following PCI, DAPT 12 months, and it can be shortened or even lengthened. Some special scenarios are there where the patient may need to have triple therapy, particularly the patient has got atrial fibrillation. So here default strategy is that the patient should have triple therapy 1 week, followed by up to 12 months dual therapy, and after 12 months only oral anticoagulant. And here we have to special mention that the clopidogrel is the main P2Y12 receptor blocker that can be given in the triple therapy, not the other agents, although some studies are now doing on to give the ticagrelor along with the aspirin and the anticoagulants. So duration of the platelets and the dual antiplatelet therapy after DES-PCI does not differ in between the guidelines, more or less similar. But important one is that the individualization of the duration of the DAPT is very important. Personalization of the duration of the DAPT is important, where you have to consider patient characteristics, procedural characteristics, and the biomarkers. And depending on that, you have to depend on some scoring system. An important one is precise DAPT score and the DAPT score. And according to that, you have to take decision how much lengthy your DAPT therapy for your patient should be. So important was that the omitting aspirin in the PCA patient, is it a myth or reality? Now, different studies has been conducted. A lot of study you see here. The aspirin has been discontinued after 1 or 3 months after DAPT therapy, and thereafter only the P2Y12 monotherapy is continued in contrast to conventional DAPT, and they found that there is no significant difference between the ischemic events like stent thrombosis in between the two groups. Rather, there is improvement in the bleeding tendencies in the group who are not getting aspirin therapy. So what is more surprising is that some patient having stable coronary artery disease following percutaneous coronary intervention, only prasugrel monotherapy is producing better results, or even as comparable as they found that in this monotherapy based on prasugrel therapy, they found no incidence of in-stent thrombosis, and the study has been done over 201 patients, and follow-up has been done 9 months. So you see that is a very daring purpose, that there is no DAPT, only prasugrel monotherapy. So, and another host exam trial showed that the following coronary intervention, clopidogrel monotherapy was superior to aspirin monotherapy. So aspirin has been discontinued from the very beginning, and as a continuation of the therapy, it is the clopidogrel which is more beneficial than the aspirin. So is it the time to say goodbye to the aspirin? We don't want to give goodbye to the aspirin because the aspirin is considered to be a poor man's thrombolytic. In our low socioeconomic status, we don't want to lose the aspirin from the antiplatelet therapy. But the reality is very crude and is very unkind. So it is the future that will determine the fate of the aspirin. But several new antiplatelet agents intended for use among the patient undergoing PCI are under clinical development, like selotogrel, RUC4, and rivacept. So in conclusion, ladies and gentlemen, what I should say, that several patient, procedure, or device-related factors influence ischemic and the bleeding risks. Risk score might help in decision-making process, but the clinical judgment should always prevail. An individualized approach is mandatory when selecting the optimal duration of antiplatelet therapy. Future guidelines will likely accept even shorter duration of DAPT for most patients and provide consideration for P2Y12 inhibitor monotherapy. Thank you all. Thank you for patient hearing.